Over the last 7 years, we have spoken to thousands of people about what helps them to keep well and live life to the full. After a while, we started to notice some patterns, and that no matter what their health issues, age, or where they lived, people told us the same things. It all boiled down to five positive emotions. If health and care services created this emotional legacy, then people told us they coped, kept well, and needed statutory services less. If services destroyed or failed to build these emotions, then the opposite happened. We call this the emotional currency of health and care. And what we have learnt is that health and care systems trade in this emotional currency, often unconsciously. So let's look at each emotion in turn. The first emotion is hope. Hope is the emotion of recovery. It is also closely linked to good mental health and well-being. We first learnt about the importance of hope in our work with mental health service users, and since then we have understood that hope matters to most people. For instance, in those living with long-term conditions, the biggest impact of a second or third diagnosis is that it shatters hope. Even at the end of life, hope that every day can be as good as it can be is extremely important. What we need to do is to design services that build hope and raise expectations about how good life can be. We also need to measure whether services are succeeding in doing this. The second emotion is understanding. Often policymakers and those working in health and care systems use words like compassion, empathy, or personalisation. These are not the words that family and people use. They say things like, I wish they understood me. I'm a person. I have a life outside of here. I'm not my health condition. What people want is to be seen and understood by health and caregivers. This is because they want to know what matters to them matters to those who are supporting them to keep well. Professional people can't do that if they don't understand the person or the family. The introduction of care and support planning is one way of increasing understanding. We believe that people setting personal outcomes really helps to change the conversation, because working towards shared goals cements a positive relationship, and positive relationships with professionals is something that matters universally to people and families. Also, working towards shared goals builds hope. In an ideal world, we would have an outcomes measurement system operating at scale across health and care systems that measures at population level whether people are achieving their personal outcomes and analyses what those personal outcomes are, so that health and care systems can respond. That is why we're building the Life Improver Score system. The third emotion is trust. When a person trusts the health professionals caring for them, they feel reassured and safe. Trust grows from building rapport with a professional over time, continuity of care, and from feeling understood. When people fail to build trust with professionals, they keep coming back or seeking to circumvent the system until they find someone they do trust. Trust can be easily broken. When it is, people often lose trust in the whole system. In work we've done with those who frequently go to see their GP, we found that a common experience for many was that they or a member of their family had experienced a poor outcome of care. They had lost trust in the system, and this drove them to keep coming back to the surgery because they did not trust the advice they were given first time, or that anyone would follow them up and see how they were doing. We have found that proactive follow-up builds trust, which leads to less service use in the long run. This is one of the benefits of group consultations, and it is why this model responds so well to what matters to people. Trusting that you will get the help you need when you need it is also very important, and impacts on how people use urgent care services in particular. Because people no longer trust that they can get to see their GP when they need to, they head straight for A&E, regardless of whether GP access is a real issue locally. They have lost trust, so rebuilding trust is key to managing demand for urgent care. There is also good evidence from motivational interviewing and recovery that the relationship between the therapist and the person impacts on outcomes. We have found that the therapeutic value of relationships is often undervalued in the design of health and care systems. Our insights suggest that we should be doing more to build continuity and relationship centred care, and that follow up and review should be proactive and relationship centred. The fourth emotion is reassurance. Reassurance is probably the most important element of emotional currency flowing through NHS services. Most of the time, people consulting a clinician are seeking reassurance. Those who live with complex health issues talk a lot about how much they value knowing they can access reassurance from their support team if something unexpected happens. This is especially true of those who live with conditions that are exacerbated by anxiety. For instance, if people with COPD or heart conditions are able to gain quick access to reassurance, it stops their anxiety escalating and causing breathlessness that then sees them admitted to hospital. Parents of very young children, especially first-time mums who have no friends or family close by to ask for a second opinion, need lots of reassurance, which is why they may be frequent and demanding visitors at GP surgeries, and why they value the support and reassurance health visitors offer. It's also the reason why they go straight to A&E if this support is unavailable to them, or if A&E is better at reassuring them than community-based services. People often tell us that having a mobile phone number for their GP, specialist nurse or consultant, even though they may call it infrequently or never take advantage of this privilege, is very reassuring. Building reassurance services should be a big focus of all transformation programs. The fifth emotion is happiness. Happiness should matter much more than it does in health and care systems. Happy people keep well and they use services less. Happiness is an individual thing, and research shows that happy people most often have an abundance of two things in their lives: things that bring them pleasure and things that give them a sense of meaning. Social connection is usually important to achieving both. When people set personal outcomes and goals, they are nearly always focused on creating happiness by doing things they enjoy or that give them a sense of meaning. That is why we need to start to measure whether health and care systems are working towards supporting people to achieve those personal goals. When this is happening at scale, we will be supporting the creation of happiness. The evidence we have generated over the last 7 years suggests that if we design services that build a positive legacy of these 5 emotions and contracts that recognise and trade in an emotional as well as a financial currency, we will achieve transformation. We think that outcomes-based commissioning predicated on well-designed person-centred outcome measurement tools that capture this emotional currency at whole system level is the way forward. Regardless of the local model of care or organisational approach to transformation, communities in partnership with someone in the system need to set outcomes, and communities in partnership with someone need to be accountable for delivering improvement in those outcomes. Whoever that is in your system needs to understand the power of emotional currency and measure whether services are creating or destroying it. If you would like to learn more about how to measure and trade in emotional currency, contact Georgina for a discussion about how to make this change happen in your area.